Smoldering myeloma is again an area of great interest. It's an area where a lot of research is being done. And the idea behind trying to do work in smoldering myeloma is, if you want to cure a disease, why not get to it early before it becomes full blown? And why not prevent the progression to active multiple myeloma, which we know is, if in not treated appropriately, is probably fatal in the majority of patients. I do think that is changing with everything we have available for the care of myeloma patients. So that's sort of the impetus to want to treat smoldering myeloma. It's very few diseases like myeloma which have a precursor disease state wherein you can identify these patients and then consider treatment. I think our biggest challenge in the smoldering multiple myeloma space is how do you define high-risk disease? And we have now come up with several different approaches. I think the most recent approach of using the 20-20 definition, which the Mayo Clinic and the International Myeloma Group has validated. And what it really is where you have 20% plasmacytosis, you have 2 grams of protein, and you have serum free light chain ratio of 20 or greater. And depending on the number of these risk factors, you can then kind of estimate your rate of progression. So even if patients have all 3 of these risk factors, there's about, your risk of progression is somewhere between 50 and 60%. So even with this really robust and good model, we do find that 40% of patients are actually not going to progress to full-blown myeloma. So even if we include all of these patients in some of the clinical trials which are ongoing, we may be overtreating 40% of patients. As I've mentioned already, there's a lot of different trials, and if you go on to clinicaltrials.gov, you're going to be overwhelmed with the number of clinical trials which are happening in this space. And they're, from the very early sort of non-myeloma-like approaches to full-blown treatment with transplant, 4 drugs, and so on and so forth. And I think we're still trying to figure out which patients need to be treated. So the data which has recently been presented and now published is the ECOG trial comparing lenalidomide to nothing at all. And in that patient population, what you saw was high-risk smoldering myeloma was defined. Again, the problem was the study was done even before the IMWG had the actual new definition of symptomatic active myeloma. So some of the patients included in that trial already had myeloma, but that trial was used, and what it showed was a progression-free survival benefit. I don't think that should change the standard of care for smoldering multiple myeloma, because as of right now, I still think smoldering multiple myeloma should be a disease where wait and watch should be the policy, and we should be treating patients only on clinical trials until and unless we try and refine our definition of what high-risk disease is. And that's ongoing work. And once we can really identify, yes, this is a patient who is absolutely 100% of times going to progress to multiple myeloma, then intervening in that patient population will become the standard of care. And we may actually, in fact, change the definition of what smoldering myeloma is. We may actually call these patients active disease and treat them with the best possible approach. Until that happens, we need to continue to do our work in this space, and our work should be around continuing to identify risk factors to better define who are the ones who are going to progress, and then identify the best possible options. And as of right now, my recommendation would be treat patients with smoldering myeloma in the context of a clinical trial only. Otherwise, the standard of care for a smoldering myeloma patient should continue to remain watchful waiting.